So I'm going to talk a little bit about the sort of Centre of Excellence proposal that we've been trying to sort of pull together for a little while now. I would like to pay my respects to the traditional custodians of the land on which we walk, work, talk and live, and also to acknowledge the elders past, present and future. And for my sins, I'm actually a clinician, but I actually am the medical director of child development services in Brisbane, and so I have sort of a little bit of a role in trying to make stuff happen or get stuff done, as you might expect. But I also am the director of a clinical trial, Centre for Clinical Trials in Rare Neurodevelopmental Disorders, which was set up with initial seed funding from the Queensland Government about 6 or 7 years ago. And we've focused very much on a mission to enable access to trials for families of children with rare disorders. Autism is in there, although it's not a rare disorder. There are multiple rare causes of autism that fit into that model, and actually it brings in money to allow us to function. So we work with autism, 22q11 deletion, Fragile X, Angelman's, and all of those drug companies are drug companies we have been working with. But speaking to some of the things that we've talked about earlier, we try and hit the drug companies up to actually make sure there is open label access at the end of their randomised control trial so that everybody gets a benefit from taking part in that trial potentially. And for a number of the drug companies, we've actually asked them to actually fund the patient voice. So we've been doing interviews at the end of the trials to look at the patient experience of taking part in those trials. But I digress a little bit. The Queensland story is very much that we've had an integrated Prader-Willi clinic for many, many years, ever since I first came back from the UK in 2002. It's been running in some format ever since, despite the changeover and merger of 2 hospitals. It's largely been driven by endocrinology and nursing, sleep medicine and nursing as needed, general paediatrics and developmental paediatrics, but fairly sort of pushed for funds and arguing the sustainability over many years. We as clinicians have identified a number of gaps in what we can provide within a public health system, and I sort of fluctuate between the clinician, the advocate and the public health manager in that space. We know families feel lost when a diagnosis is first made. Where do I go? How do I find out what's right? Seeking help can be a real battle, and not every family is health literate enough to know where to go. Lots of things to take in that can be overwhelming. There may be poor coordination with multiple subspecialists. As health has evolved, I'm feeling a bit old here, but the more we've evolved, the more siloed our health systems have become. And in paediatrics, we're not fantastic at it. Well, I think we're getting worse at it. And adult medicine, it's even more siloed. And I think it's a real problem for us moving forward. Local health professions are often at sea. There's a rare disorder I don't know anything about. How do I sort of Google it and find out what's going on? As time goes on, for Prader-Willi in particular, the trajectory is different and it changes. So keeping up with stuff is really difficult. And that transition between paediatric and adult care, there are very different philosophies within the health system, and it can be really tricky. So there are a few sort of rare care things that are happening around the country. In particular, these are really dependent on whether families find the right person to talk to or not. And there are a few initiatives. There's the Rare Care Centre in WA, where people can be plugged into services a little bit better, but it's not really ongoing care, and that can be really tricky. And there's a couple of sort of things in the terms of trying to educate professionals around rare disorders, and Emma Palmer's been doing an ECHO, which is basically a community of practice where people log on and learn about rare disorders, but it's not specific to Prader-Willi syndrome. It's often, to me, the simplest things that help. A personalised plan for the family and the child, coordinated care, a single point of contact, integrated care, both there we go. Integrated care vertically is from the super expert to your local GP, so making sure communication happens. Horizontal integrated care is between all that multitude of subspecialists that you might have to see, and Prader-Willi has to see a few. And then it's actually also horizontal integrated care, if you like, at that primary care level where you as parents or people with Prader-Willi syndrome are trying to interact with not only the health system, the education system, the social services system, and the disability system now. That's one thing the NDIS has created, is a whole other system for families to work with. And we know as developmental paediatricians the amount of increase of work that has taken. About 60% of our time is now taken up writing letters for the NDIS and supporting that integration. So it's a complex system that a person with a disability of some description sits in. So integrating vertically and horizontally is really important. We know that collaboration is key. Jessica Dewis from Colorado University has set up a number of clinics for a couple of rare disorders. Angelman's and Prader-Willi are two. And really that centre of excellence approach where you have a number of integrated subspecialists that are working, that are expert in a particular disorder, really drives a better understanding of that molecular basis, better clinical outcome measures, and really sort of identifies those gaps in practice. We know from the Pittsburgh work that, you know, when you have better care coordination, you have decreased hospitalisations, decreased emergency visits, a decrease in failure to attend rates, missed school days, caregiver missed work, and caregiver stress levels. And we know that from some recent work we've done by appointing a nurse navigator for autism, who sits at a statewide level and navigates the health system for people with autism. The amount and the reduction of attendances at emergency crisis presentations has vastly reduced by appointing one person. And the health services impact of that is something like 10 to 1. So the cost to the health system of appointing a single nurse for the state of Queensland in paediatric autism has been huge. So that's what speaks to health systems. You know, it doesn't matter, all the touchy-feely stuff doesn't matter, but if you can tell them they're going to save $1, that's when you'll get money out of a health system. So we need to really look at that. So what we're proposing, we're really trying to make sure it aligns with everything, okay? So aligns with the National Action Plan for Rare Disorders, aligns with the Prader-Willi Research Foundation's key pillars, aligns with the UN. We need to make sure that we are aligning with everything. Australia, we have distance here and vast proportions of the country where people do in fact live. I grew up in the middle there, okay, so quite different. But what you find is that somebody from the Northern Territory or, you know, the Northwest may have to spend thousands of dollars getting to a clinic, okay, and that can be really, really difficult. The one big plus out of the last few years has been clinicians have got much better at using telehealth. I don't think I've changed a lot because I was already doing telehealth clinics monthly and weekly in some circumstances. But in fact, we now do regular telehealth clinics. So the ability for us now to establish a virtual networked centre of excellence across multiple clinics is really there because we've now got capacity to do that. We as a clinical trial centre in Queensland we had patients enrolled in our clinical trials from WA, from South Australia, from the Territory, all through COVID. But using telehealth and local GPs, we did not lose any data from any of those clinical trials. So it is possible to do. So we see really this virtual networked centre of excellence comprising people from all over Australia, being experts in Prader-Willi syndrome, not necessarily all aspects, but bringing them together. Supporting local care. Paediatricians, we don't need people to be travelling all the time. But then that universal care across education, disability. And I strongly believe you need a rapid access to expertise from a patient and a clinician perspective. There needs to be a really strong clinical role within this, early connection and interventions, personal plans, international partnerships. I know that our 22Q11 integrated clinic very rarely has children that present with psychosis. Now, the 22Q11 group has a 30 to 40% incidence of psychosis in early adolescence. But with really good early care and early management of anxiety and ADHD symptoms, we don't see that. Most of the patients, probably 80% of the patients presenting with psychosis in Queensland, are children who've never been to our clinic, who've just turned up randomly and had a new diagnosis. So early care, prevention, I think, is where it's at, particularly with that adult mental health perspective. Education and standard setting. How do we communicate best practice to those NDIS clinicians? You know, a lot of NDIS clinicians are babes in the wood. They've just come out of uni. They're earning a lot of money. How do we help them get to the point where they're actually experts in not only the individual, but also in the Prader-Willi syndrome? And how do we facilitate research? I don't think research can exist without clinics and expert clinics, because that's where data can be collected. You know, that's where things can happen. So really good natural history programs, really good data, symptom management, and genetic therapies coming through, which are clearly there. So I'll just briefly go through some of this. So multidisciplinary clinics, it builds experience. Nobody picks up a book and reads it and says, I'm an expert in Prader-Willi. Most of us have hung around people with Prader-Willi for a long time to actually understand it. We learn from families and patients. So the role for families and patients is absolutely key. But when you have a clinic that is multidisciplinary, you can translate knowledge into practice really quickly. So it actually starts to bring those clinical trials through. We can develop those standards of care, and we've done this with the Angelman syndrome group really nicely, who is also worked with Jessica Jewis. We need that digital integration of health and research portals. Now that's really tricky. You know, electronic medical records are great, but when everybody uses a different one, it adds complexity to this picture. So we have to work through that. We need to make sure patients and families are part of that partnership and get that coordinated care right with the NDIS, because I think that is a really tricky interface at the moment. And support families with, you know, one of the key roles with these navigators or nurse coordinators is really supporting families with that health literacy and system literacy, which is really tricky and difficult, and well-being. When is something going wrong with the family? When is it okay to say, you know what, no therapy for 6 months, I'm just going to be, and that is actually okay. Those early linkages, streamlined access, you know, for the other centre of excellence we're working with, the Angelmans, we've got a 1300 number and we've got a single email. We've got nurses across Melbourne, Sydney and Brisbane that cover the week. They all use the same email. It's all the 1300 number. And depending on the day, you might talk to someone in Victoria, but actually they take some information and they flick it to the person who is closer to you. So it kind of works really well. We're just getting started with that one as well. So that clinical modelling is really important. I think that the sort of multidisciplinary clinic and that networked thing, so you know what to look out for, is really important. So we can start to screen for these developmental and behavioural things really early and intervene really early. I think this is just an example from some of Tony Holland's work that I sort of have worked with for a bit over the years. One of my other hats is on the chair of the International Society for Behavioural Phenotypes, the study of behavioural phenotypes. So I've had a lot to do with Tony and Kate Woodcock and those guys that have done a lot of research into adult mental health. And so understanding that expert sort of research that's gone on and then thinking about that challenge with set shift might look like ADHD to the uninitiated, but it's actually transitioning between behaviours or thoughts that can be really tricky. And so how can we use this research in a clinical paradigm to help and support people that are actually implementing the interventions at an NDIS level? Education support is really the way to go, I think. The ECHO model is a standardised model that they use to develop better practice with hepatitis C in the US, and it's actually evolved around the world now. And do we develop an ECHO for clinicians in the NDIS around Prader-Willi? That's some random thoughts I had. The standards of care, I think, are absolutely key for people to come together on what information we collect and what do we do. Then there's all sorts of other things such as websites, webinars, etc. that we can be supported with. Research, I've talked a little bit. We need comprehensive and national sort of standards of care and what sort of clinical proformas we will use. We need a platform for local collation. And we do have those around. There's various open source platforms we could use. Then clinical trials, and as Sue was alluding to, the clinical trials in this space for rare disorders is really tricky and can become really competitive. That's been one of the problems with the Angelman syndrome community, is there's about 10 trials going on at the moment. And when you've only got a small number of people, you're going to struggle to figure out how to make that work. So do we start to move to more adaptive trials, N=1 trials, those sorts of things? The old sort of approach of, 300 people in a randomised control trial is not going to work for rare disorders. And I think it's a real challenge for the NIH and the FDA and, government organisers are really struggling with. And then this bit, I think, is going to be really important, the health system economics in terms of creating better outcomes in the long term. Governments listen to money, and we have to get that right as we set this up. Be mindful of the life course. We need to go right through the life course and acknowledge that actually there are some really tricky points in anyone's life that we really need to address better, which the health system doesn't do at the moment, and particularly around transition and particularly around diagnosis. Need to collaborate and focus on those outcomes that are important to families and create a learning adaptive system, I think, will be really important with that continuous cycle of improvement. We need to create that centre that clinicians can access for support, knowledge and communication with that vertical integration. But we've got to start. If you wait till we have all the money, we're not going to get anywhere, okay? So we're going to start with coordination is the plan. And we're going to start with new diagnoses. So getting nurses on board to coordinate and develop the standards of care and focus on getting those new diagnoses in the right place. Then build on that and plan from there, but make sure health economics and evaluation from all of those people is there from the very beginning. So we're thinking about a bit of a plan, how we move forward, those sorts of things. The next 6 months is getting 1, 2, 3 sites on board, getting the health services evaluation stuff on board, and then setting up the systems to move forward with proformas. And then the world's our oyster. That's it.